We're going live. Thank you so much for your patience, okay? Very grateful. So we are starting our first bill hearing for the session, and we're starting with House Bill 214, Delegate Kelly. The rules are as follow in the committee, and today I'm going to make them really short just so that we can go right on. The sponsor of the bill does not have any time limitations, but we hope that you are reasonable, okay? And then every other witness has 2 minutes after that, and you'll see the timer where it says blue sky timer. For the committee members, you can ask a question of one witness, right? Not everyone. And please, if you have asked a question already, you don't have to feel compelled to ask a question of every panelist. They're available for you after the hearing. You can actually call them, or better yet, ask the sponsor of the bill to give you the information that is requested. Today with us, we have our wonderful counsel, Aaron Hopwood, who actually is a lawyer for the attorney that handles a lot of these bills as well. So we're going to get started because we have 16 witnesses. So Delegate Kelly, will you please start on House Bill 214 titled Commission on Public Health Establishment? Thank you.
Thank you so much, Madam Chairman and members of the committee. I'm so excited to have the first bill hearing back in person in a long time. So I will make this quick because we have had a long afternoon. This is a fun bill. I heard there's 16 witnesses, but I hope we get a lot of Me Too's, and what a great idea coming our way. So House Bill 214 establishes a commission on public health to begin the work to evaluate and update our public health system in Maryland. Why do we need this? Over the last 3 years, 16,000 Marylanders, 16,000, have lost their lives to COVID. Under the circumstances, I am proud of how we as a state have managed the pandemic. It has not been easy, but we have come together and we have saved lives. Still, our collective experience within the last few years has shown us, I think without a doubt, that we need to invest strategically in our public health system. So what is the future of public health in Maryland? Public health is, according to Dr. Sharfstein, what we as a society do collectively to assure the conditions in which people can be healthy and thrive. In Maryland, we rely on the Department of Health and 24 local health departments to provide essential health services, public health services. Services that include keeping our food and water safe, reducing the spread of infectious disease, helping people quit smoking, improving birth outcomes, and so much more. Most of the time, public health is invisible. But during the pandemic, however, the work of the public health became highly visible and something that all of us were talking about. And what we saw in Maryland, as we saw around the country, was a system that sometimes struggled to serve the people in a moment of crisis. And we know that we can be doing better. Despite Maryland being one of the richest states in the nation, the Centers for Disease Control recently ranked us 25th in life expectancy, 29th in infant mortality, and 45th in drug overdose deaths. So these unacceptable rankings have two important things in common. One, many of these deaths were preventable. Preventable deaths leave us all asking, what could have been done? What more can be done? Number two, these tragedies do not affect all groups equally. The lowest life expectancies, the highest rates of infant mortality, the highest rates of COVID mortality, and the highest rates of drug overdose deaths all are among people of color. This bill would establish a commission to study Maryland's response to major public health challenges, including COVID, maternal health, drug overdose, and make recommendations for the future. To start a conversation about what doing better looks like. As we begin this conversation, I want to be absolutely clear, like all of our healthcare workers we've been talking about all day, during this pandemic, our public health workforce has been heroic. They worked hard to make sure we had access to masks and medicines and vaccines. Yet as they did this, they struggled to use old systems to report the information people needed. They had to rely on outdated human resources and procurement systems. We spent all afternoon talking about this already, to quickly hire the staff and build the partnerships they need to do the work that is important. They did their best, knowing the whole time that it could be possible to do better. So how will this bill get us to better? It establishes a commission. Right now, that commission has 19 proposed members. You're going to hear from us a lot of interest in parties who want to be added onto that commission. Those of you who have been around a while know that this happens all the time with commission bills. We want to make sure we're not making it too big so that it is still productive, but we will certainly consider the requests from all of the individuals who want to be added on in the Public Health Subcommittee. And I want to thank Erin Hopwood in advance for her help sorting all of these requests out so that the subcommittee can make any refinements that are necessary to the commission membership. I also want to note that the language in the bill allows for the formation of work groups, which is something that we used as a model with the Healthcare Workforce Commission we just heard from. So not everybody needs to be an official member of the commission to have their voice heard. The second thing that the bill does, in addition to establishing the commission, is it requires the commission make an assessment of state and local health department capabilities for providing foundational public health services. Right now in the timeline, that assessment is due October 1st, 2024. The commission is required to make recommendations for any necessary reforms by October 1st, 2025. You're going to see in your file a long list of organizations supporting the establishment of this commission, so I will not read it for you, but it's a lot of really wonderful stakeholders who are excited about doing this. You will also see that in addition to suggestions for commission composition, there are a few suggestions about tweaking the responsibilities and scope of the commission. So again, we will have this discussion in subcommittee this coming week. I have with me here today Dr. Josh Sharfstein, who is a familiar face to many of you, but for newer members, you should know that he really does have an understanding of public health and the role of state government. He was our Secretary of Health under Governor O'Malley. I also have Dr. Keisha Davis coming to us over Zoom, who is the Public Health Officer for Montgomery County. She's a family physician with a master's degree in public health from Johns Hopkins and a background in community health and health equity. So these are the experts in this work. I'm just here to make the case that we can and must do this work together for the sake of public health in Maryland. So with that, I'm going to urge a favorable report and pass the mic to Dr. Sharfstein.
Thank you. Good afternoon, Dr. Sharfstein.
I think she'll turn it on for you.
There we go. Thank you so much for the chance to come. Thank you so much, Delegate Kelly, and thank you so much, Madam Chair. It's great to be here. It's great to see you. Great to see Delegate Kipke, my own delegate, Delegate Rosenberg, and all the familiar faces from 8 years ago. The internet is much better now here since I was here, but otherwise the important work continues. I saw Delegate Hill somewhere. Oh, there she is. Excellent. So I'm going to be super brief because that was a great introduction to this bill from Delegate Kelly. I will just say three things. First of all, I work before I say that, at Johns Hopkins now. I'm the Vice Dean for Public Health Practice and Community Engagement at the School of Public Health. I have here that my views do not necessarily represent those of my employer, Johns Hopkins, although on the way over here, I learned that Johns Hopkins will be supporting the bill, which is always a pleasant thing to read about, to hear about. So three quick things: the rationale for the commission, what other states are doing, and the opportunity of the commission. The rationale, I won't say much more than what Delegate Kelly said. This is a moment, given the incredible stress that we have been through over the last 3 years, that this is the first in-person hearing in 3 years, I heard. We have been through an awful lot. There's a moment to really learn from that about what can be done better, and to put the state in a position not only to be better prepared for a pandemic, but to be doing better against the kinds of challenges that Delegate Kelly mentioned that threaten health and lives of people in Maryland every day and really do undermine equity for Maryland citizens. Number two, I want to point out that the approach that the bill takes is very similar to the approach that other states are taking now to address their public health systems. Indiana had a huge commission recently engaged, looking very similarly at how the state is meeting the foundational public health needs of the population that are just things we take for granted, but we can do a lot better. And Ohio has had a commission like this. Washington State, Michigan, Massachusetts, Oklahoma have all done variations of this kind of thing. So the idea here is to really understand the needs for public health, how we've been going about meeting them, and what can be done better. Finally, the last point I make is teach a class at the School of Public Health. When I got to the School of Public Health and they said, what class do you want to teach? I first said public health policy, and they said, we went to all these committees at Hopkins, and then they said, rejected. I said, rejected? They said, yes, we already have a class called public health policy. So then I tried to say, like, decisions in public health policy. That one got rejected too. All my original courses, they already had classes. So they said, why don't you teach a class that maybe you would have wished you had taken before you became Secretary of Health? And so I've been teaching a class called Crisis and Response in Public Health, because the experience of being in these jobs, there's a lot of crisis. And so I wrote a book about crisis. I've been teaching it for 8 years. And one of the big lessons is what happens after a crisis. Do people just put it in the rearview mirror and just try to, get back to business as usual and not take a moment, or do they, in a way, honor the victims of the crisis and look thoroughly at what happened and really try to draw lessons that can be the building blocks for avoiding problems in the future and saving lives? And that's really what this bill intends to do. So thank you very much.
And thank you for your work and for being available to work on this bill. Are there any questions? I see Delegate Kaiser. Oh, one second. You're right, we do have a virtual witness, and we'll wait. Don't worry, I'll get used to this. So the virtual witness that we have is Ms. Keisha Davis, and she's the Montgomery County Health Department public officer. Good afternoon, doctor, and thank you for your patience. You can get started.
Great, thank you. Good afternoon. Thank you, Chair Pena-Melnick, Vice Chair Kelly, and members of the Health and Government Operations Committee. I'm Dr. Keisha Davis, a family physician and Montgomery County's local health officer, here on behalf of Department of Health and Human Services to offer support for HB 214. As was already mentioned, along with frontline healthcare workers, county health departments were at the forefront of public health delivery during the pandemic and have on-the-ground insights into many of the areas that will be studied by the Commission. This includes lessons learned from COVID and strengthening the public health infrastructure to better anticipate, respond, and protect Marylanders from future pandemics. This bill will also allows the opportunity to study those best practices and recommend changes that will improve the general health of Marylanders and reduce the health disparities that plague us. Because of the importance of addressing health equity in this report, that expertise must exist in more than just one member of the Commission. And I recommend that experience in health equity be criteria through which all persons are evaluated for membership on the Commission. Montgomery County is proud of our combined health and human services approach to public health services delivery and believe that this structure enables us to meet the holistic public health needs of our residents. And we ask that the Commission recognize that counties have different needs and capabilities, and a variety of models may be effective across the state. And to that end, it will be important to have representation on the committee from small, medium, and large health departments. We need to act quickly to capitalize on the lessons learned from COVID and work to a stronger, healthier Maryland. And I encourage a faster timeline for the report in order to more quickly implement the needed support for public health infrastructure that will be suggested by the Commission. And in closing, I support HB 214 and its endeavors to really take a clear-eyed look at the essential work of our state and local health departments and ask the committee to issue a favorable report. 5 seconds to spare.
Your timing was perfect. For the rest of you, learn. Anyway, this for the new members of the committee, this was the first sponsor panel, and the position is favorable. So I'm going to open it out for questions to see if you have any questions for this panel. I'm going to start with Delegate Morgan, followed by Delegate, actually it was Delegate Kaiser, followed by Delegate Morgan. See, Delegate Woods, I'm fair. Okay, go ahead.
Thank you, Madam Chair, and thank you, Delegate Kelly. First of all, I think you should retitle this, of course, the Blueprint for Maryland's Health Future, if you hadn't already thought about it. I had 2 questions, but I want to save, I'll save the better one for later, or the better one for now. On the 4th page of the bill, you talk about consider the following factors, and then on the next page, look at other factors, but no more than 3 additional factors. What were you were you afraid of this being a bottom of page 4, top of page 5? Were you worried about things running away, there being too much, too little? It was open-ended, but then not. So I was just trying to understand what you were going for here.
This may be a part of the bill that gets tinkered with a little bit. I think the idea, this is part of the assessment. The work of the commission would be in 2 steps. One would be an assessment step, and then would be recommendations. So what you probably, this year for assessment, for example, the following year for recommendations. And the question is, through what lens would we do the assessment? And so COVID is an obvious lens for the assessment. And so the idea is you can't do the assessment through every possible lens. You know, but it is helpful to be concrete. You could do a kind of an abstract assessment about HR, you know, contracting, data, but putting it into specifics with a problem or two will bring it to life. And so that's the idea there, but I think we'll want to probably narrow it somewhat, I think, and maybe have a focus, but be able to explain the implications for other issues without trying to do a full report on every issue that's possible.
Thank you. Next, we have Delegate Morgan. My pleasure.
Dr. Sharpsky, obviously this commission is set up to be the main foundation for public health policy in the state. You would agree with that, I'm sure. My question is, do you see anything like over the last couple of years dealing with COVID where this commission would have made a different decision than just what the CDC has advised?
So I think this is going to be a commission that talks about the building blocks of public health response. So things that frustrated all of us, like why did it take so long for vaccines to be easily distributed? You know, I'm sure everybody remembers how hard it was to get the computers to work and everything had to be, you know, put together quickly, or testing to be available. Those kinds of things, how we get data to flow. It's really about the building blocks. I don't think this is going to be about rethinking individual, you know, decisions during the pandemic as much. It's sort of like, this is really about like the infrastructure of public health.
So more infrastructure hands-on than policy making.
Yeah, exactly. I think, do we have, because you don't know what the policy challenge is going to be next,
Okay.
you know, and you want to have the system to be able to respond to it as well as possible.
Thank you for your answer. Thank you, Madam Chair.
My pleasure. Delegate Shalega.
Madam Chair, thank you so much. So if I'm reading this right, it's a commission that's going to study these 4 things, possibly a couple more, be in effect for 4 years, produce a report to all of us and the public. Is that right?
Yes, although as Dr. Sharpstein mentioned, in subcommittee, I think we might be looking at the timelines that some of the recommendations we have heard. So don't be married to that. I expect
Okay.
it'll come out of subcommittee slightly modified and certainly narrowed in scope. One of the things we heard from the Healthcare Workforce Commission we just heard from was, please don't give us too broad of a scope of things to look at in a short timeline.
But we're not talking about setting up a commission that'll go on for eternity. Okay.
No,
so-
definitely
okay.
not. And the only thing I would say is, I think it's really about those core building blocks of public health, and the issues are just to help us understand those.
And obviously looking at COVID, the response and, you know, what did we do right, what did we do wrong, and that kind of thing. And I noticed that the fiscal note is 0. And then I noticed finally that there is an unfavorable testimony from the Maryland Right to Life saying that this bill would use public funds for the promotion and commission of abortion. So I read the bill, and I'm asking, is that a correct assessment of the bill?
But no, I don't think so. I don't think they're public funds, and I don't think it relates directly to
I didn't
abortion.
see abortion in this bill.
No.
It's COVID, it's the pandemic.
Yeah, it's about core public health function. It's not about abortion.
Okay, thank you.
My pleasure. Delegate Rosenberg, followed by Delegate Taveras.
Thank you, Madam Chair. Josh, you were co-chair of the transition team's public health subcommittee, however it was designated. I think I know the answer to this question, but I'm not sure. Was some of the issues that this commission would address, were they in any way, shape, or form touched upon by your transition team? That is this something that the governor is a part of, ready to work on. So whatever the right phrase may be.
I mean, I obviously, I'm not going to speak for the governor, and I think the department will weigh in on the legislation. I would just say that these issues we heard time and again, because the transition had public meetings, there are a lot of people involved in the transition, that this is really a moment of opportunity to be thoughtful and think through the public health system. So I think that was absolutely a theme that we heard, but exactly how the administration comes down on the bill, I would defer to them.
Thank you. We have Delegate Taveras.
Thank you. Thank you, Madam Chair. Thank you both thank you all three of you for coming forth and testifying favorably on this really important bill. I represent a district that obviously was the most affected in terms of having the greatest number of COVID-19 cases in the whole region, which was 20783. And I live in that zip code. So I can testify not just to the need for what I saw on the ground and how I was forced to assist my constituency very much on the ground. And we had a lot of people here in this room that I'm sure were closely to bring services to our folks. Now, one of the things that was highly frustrating were that we were literally the last to receive testing sites and the last to receive vaccines. And it was very frustrating to see that we were focusing the dispersion of vaccines to homes that were literally almost meters and miles apart versus people that had 10 people to a household. And so to that end, I guess I just want to share with you, or at least with the commission, because we're going to pass this, but outside of it, I want to share with you a report that I worked with an elite engineering group that we took to the White House that resulted in the creative ideas that we saw at the supermarket, vaccination at the supermarkets, at the clubs, in nightclubs, and in bars, and et cetera, and we took that nationwide. But I want to share with you where that report, where that came from. And hopefully we were...
Delegate, what is the question?
No, the question is, is that going to be considered? Because what we did afterwards was that we created a study, that created a survey and analyzing the responses of the immigrant community to assess how they felt that government responded. Are you willing to take that step to engage in that kind of survey so that people can assess the response?
If I could just briefly respond, I think that exactly what you're talking about relates to a core public health function, and the difficulty that public health had making sure that communities at the highest risk were reached, and what was evident not just in Maryland but across the country. And so how do we rethink public health so we don't start off on the wrong foot again? It's incredibly important, and I would be very interested in seeing that. Just even though I was at the School of Public Health, I volunteered with the Maryland Health Response Corps, and I got to go to supermarkets in Southwest Baltimore. At first I started as medical consult because I'm still a licensed physician, but then I did anything they asked me to do, including Spanish translator, drawing up the medicines, giving the shots. So those kinds of things, we had a lot of people vaccinated that way.
Any other questions? Delegate Chisholm.
Thank you, Madam Chair.
My pleasure.
And either one of you can answer this, but I was looking on page 6 of the bill under section 5, subsection 2. It says, if the commission cannot reach consensus on its recommendation, the commission shall include the opportunity for dissenting comments in the commission's final report, which I find fascinating with 18 to 19 people reaching a consensus. Yeah. Do you envision that if you just have one member of the commission that has a dissenting view, would that be included, or are you envisioning it has to be 4, 5, 6 members saying we don't agree with the view of the commission right now? Because I would imagine with 18 to 19 people, and I know they all are from the same industry and might have the same philosophical views, you're going to have a lot of consent, and then where does that put the recommendations? Is it going to be a majority of them, 10 out of the 18, or do you feel like they'll be able to reach a consensus on most of these issues? Because I think in today's world, it's tough to get a consensus on where to eat breakfast,
Go ahead, if you go on.
I was going to say that this is actually something a challenge I've faced on a number of different commissions. And generally, as we're developing the reports, if it's if there is a minority opinion on something they feel strongly about, we've incorporated it in the report and represented it as a minority opinion. But this is also a really good topic for us to look at in the subcommittee. We could maybe refine the language and be more specific, which I think is what you're getting at. We have a one question, one answer policy, so I will be curious about Dr. Sharfstein's answer, but we could bring that up in the subcommittee.
Yeah. I was just going to say Ms. Shirley's would be my recommendation.
You're going to get an opportunity in subcommittee to work it out and discuss it and decide, the committee will decide what it wants to do, right? So this is the beauty of a committee like this, is that we do all our work in subcommittee, which all of you are members, right? And you decide. And it's very open and everyone can come. HGO allows everyone to come to the subcommittees as well. Any other questions? Seeing none, thank you so much for your testimony today and for your work. And next, we're going to go into witnesses that are favorable, and they're individual people. They have actually want to opine. And the first one we have, it's in Annie Coble from Johns Hopkins, and it's a favorable position. Are you here? Good afternoon. Is it Coble? Did I? Oh, all right, great. Good afternoon.
Good afternoon, Madam Chair, Vice Chair, members of the HGO Committee. Thank you for your time. My name is Annie Coble, and I'm Assistant Director for State Affairs for Johns Hopkins University in Medicine. And I'm here to express the institution's support for HB 214, establishing a Commission on Public Health. Johns Hopkins has a great deal of expertise in public health and appreciates the state's acknowledgement of the importance of this field through the Commission. Not only do we meaningfully inform public health through our research and the healthcare we provide directly to communities across the state, but public health impacts all of the elements of what we do. For example, Johns Hopkins is an overdose response program providing naloxone through all of our emergency departments at all hours of the night. Johns Hopkins research also plays a key role in public health policy and program development. I hope this explains and shows the wide breadth of areas that public health has and the importance of dedicating more resources to this discipline through establishing this commission, and we urge a favorable report.
And if I may, I'm going to call, because it's also favorable, Dean Lashnick and Pam Casemeyer. Will you be so kind and come up, please?
Do you want me to stay?
Yeah, you can stay, because we're going to open it to questions afterwards. Good afternoon.
Good afternoon. Thank you so much, Chair Pena-Melnick, Vice Chair Kelly, and members of the Health and Government Operations Committee. My name is Boris Lushniak. I'm the Dean of the School of Public Health at the University of Maryland in College Park. So when Josh says the School of Public Health, there's actually a reminder there are 2 schools of public health in our state. I've been there for 6 years, but prior to that, for 27 years, I wore the uniform of the United States Public Health Service Commission Corps. Spent my time at CDC for 16 years, 6 years at the Food and Drug Administration, running the Office of Counterterrorism and Emerging Threats, and then 5 years in the Office of the U.S. Surgeon General, where I was honored to serve as the Deputy Surgeon General for 5 years and the Acting Surgeon General for about 1.5 years. Why is that important? Well, in the midst of that career path as a public health practitioner, not just as an academic dean now, a key feature for every single response that we conducted for public health issues, public health crises, was always the concept of a hot wash, right? Afterwards, you'd sit down and you'd say, what went right, what went wrong, and what have we learned in the midst of all this? And I'll submit to you that the formation of a commission like this is, in essence, a hot wash. It is the ability for us to look not just at a crisis situation, right? Not just the pandemic, but in essence, the syndemics, as I've termed, the multiple crises that always go on in public health. You know, we talk about the syndemics of gun violence, of political upheaval, climate change, racism. Add to that the issues of chronic diseases. Add to the issues of substance abuse in our society. All these are public health issues. We have to be better as a state. As a state, we have to be better in our public health response. So I'd like to put in a favorable with the idea that this commission, I think, can move us forward. I would put in also recommendations in my written testimony about looking at the composition of the commission to reflect consumers as well as further representation of our health officers, looking at rural, suburban, and urban communities, and then also looking at the timeline, moving up the start date and reporting deadline of the commission. But as a public health commissioner, as a public health practitioner, and currently as the dean of the School of Public Health and our flagship university, we certainly are supportive as an institution, personally, and as a School of Public Health. Thank you so much for this opportunity.
Thank you for your work. We appreciate it. Pam Casemeyer.
Oh, I guess we're all on. Hi, my name's Pam Casemeyer. Today I'm here on behalf of the Mid-Atlantic Association of Community Health Centers. I did want to say before I make my comments, as you all know, and I'm really looking forward to working with all of you, and you'll see us a lot, our firm and my partners, we represent a lot of interests that come before this committee, and I'm sorry I haven't had the opportunity to meet all of the new delegates, but I wanted to say that we have a number of clients who would have weighed in at this hearing, but we didn't have time to meet officially, and they have protocols for taking positions on bills. So they will be at the table as well. On behalf of the community health centers, which many of you may not know, federally community health centers are located in medically underserved communities. They serve mostly under lower income Medicaid, uninsured people. They are the public health providers in the medically underserved areas, and they're really excited to be able to talk about a lot of the things that are in this bill. Just as the dean said, I think I'm not here with specific amendments, but there are a number of issues that I've heard from people as they've looked at the bill that we're looking forward to addressing in the subcommittee, such as whether we tighten up a little bit the description of who the members are, or whether we even define specific work groups and create some subject matter around that so we have the right people at the table for the right subjects. The question about whether we have the right factors we're looking at for assessments or need to change or adjust those kinds of things I think we'll work through in the committee to be sure that we have the right people at the table and the right charges to do what the objectives of this commission are. And with that, I will end my speech.
Thank you so much. And now we will have a question from Delegate Hill.
Thank you very much. Dean, I just wanted to point out, I think there are at least 3 public health schools in the state, including Morgan State University, and we could also count the uniformed services in Bethesda. I just want to make that point.
They're actually, you're absolutely right. There's multiple public health programs in the state, but only 2 schools of public health. So we actually are all part of an association of schools and programs of public health. We actually added the second P to that. But no, we are all friends amongst each other. And I do have to say, I think that brings up an interesting point, which is oftentimes we look at the schools as the only educational pathway in our state. No, there are excellent programs, as you mentioned, within Morgan State, the Uniformed Services University, which is formerly I served as a chair there in preventive medicine. Yes, there are incredible pathways, all of which can get involved in something like this, in this commission. So yeah, I'm 100% supportive of that. Thank you, Delegate Hill.
Yeah, Delegate Hill was hoping that this was isn't that so, but it wasn't. Sorry. I'm sorry about that. Any other questions? Okay, seeing none, thank you so much for your time. Thank you. Next, we have Cynthia Bauer, Dr. Larry Polsky, Matthew Celentano, Oluwatosin Olatehu, and I hope I pronounced the name correctly, and if I don't, correct me, and Kathleen Hoke. If you're here, will you be so kind and come up? Who would like to get started?
Whatever. No, you're good.
It will get, go ahead and start talking.
Great. Well, thank you, Madam Chairperson, Vice Chair Kelly, and committee members. Thank you for a few minutes to explain my favorable with amendments recommendation on this bill. I come to you as the director of the Horowitz Center for Health Literacy, leader of Maryland's new Consumer Health Information Hub, a Prince George's County resident, and a passionate advocate for consumers. My written testimony highlights several suggested changes, and my oral testimony is going to focus on what we all call the showstopper, and that showstopper is consumer lay participation. I'm in favor of this commission and this study if we can increase consumer lay participation significantly. The bill provides for only one consumer seat on this commission, no required consumer lay participation in work groups, and only 3 public hearings. I propose 50% consumer lay participation and guaranteed membership on any work groups. As a former HHS and CDC person myself, I know that agency personnel and subject matter experts know how to run health systems. But the 6 million plus Maryland residents have a range of opinions, beliefs, and experiences about public health and what they want from a public health system. Consumers deserve enough seats at the table to be heard and vote their interests. Robust consumer participation is also a health literacy issue. Health organizations call my center for help to create consumer-friendly systems because, frankly, almost no one understands how public health and healthcare works. Consumer members will not only contribute valuable expertise, but they will learn and become more invested in public health because they participate and they can carry that information home to their communities and their neighbors. Maryland policymakers pride themselves on the Maryland model for healthcare. The model promises us that we will have a people-first system that benefits all of us. HB 214 calls for a public health model with similar promises of benefits of equity for all of us. These are admirable goals, and I support those goals, but they must have robust consumer lay input and participation to be achieved. Thank you.
Thank you for your testimony. Dr. Polsky.
Madam Chair, Madam Vice Chair, members of the committee, my name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in support of HB 214 with several proposed amendments. These amendments are detailed in our written testimony. I'll quickly explain the rationale for the modifications we've suggested. To adequately account for differences in geographic challenges, job applicant pools, and forms of local government, we request that the Commission include local health department representation from a small, a mid-size, and a large jurisdiction. We also recommend that the Commission include a representative from the Department of Budget and Management. Over the recent years, many great ideas have been discussed at meetings between the Maryland Department of Health and health officers, but lack of coordination between DBAM and MDH have been a recurring obstacle to turning innovative plans into action. If we want to expedite the development and enactment of fiscally realistic public health improvements, input from DBAM throughout this process will be critical. After serving on dozens of commissions, committees, and work groups, I've observed that limiting membership to those who are essential to its core mission enables the process to move at an optimal pace. Paring back the membership of this commission should allow it to issue a finished report earlier than the currently proposed date of October 2025. Several of the proposed member positions are redundant. Licensed healthcare providers, those with expertise in public health workforce, those with expertise in health equity, and safety net providers will be well represented by appointees to other positions. And it is insufficient to have a single IT expert or consumer health advocate. At least a half dozen of each of these classifications will be needed, but they are more effectively used as members of work groups appointed by commission members, not as standing members of the commission. Finally, we know that this comprehensive study will take time, but we think that a quality report is available in October 2024. There is a cost in health and lives with each year that we postpone public health improvements. We respectfully request that the committee consider amending the due date of the final report along with approval of a more streamlined commission. Thank you very much.
Thank you for your testimony today. We appreciate it. Next, we have Mr. Matthew Celentano.
Thank you, Madam Chair, members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers in support of House Bill 214. Carriers were especially nimble during the pandemic, waiving lots of requirements in consultation with stakeholders to ensure there was immediate access to care. We had dental plans that were providing millions of dollars worth of PPE to dentists. We were on phone calls with the MIA on almost a daily basis to create modified protocols to ensure that care got out to the community. We're always focused on care coordination and population health at carriers, and we suggest that it might be appropriate to have a carrier member of the commission. On a personal note, I will just say my dad is the chair of the Johns Hopkins Bloomberg School of Public Health Department of Epidemiology. And when we were in the scariest portion of the pandemic, in the spring of 2020, my sister and I would jab him all the time and say, hey, buddy, now it's your time to shine, right? But the fact is that he had been shining for decades. And now, with the benefit of the last couple of years, I think it's appropriate to have this commission to raise or to elevate public health here in Maryland. So we urge a favorable report. Thank you very much.
Thank you for your testimony. Next.
Madam Chair, Madam Vice Chair, members of the committee, I'm Kathy Hoke, a professor at the University of Maryland Carey School of Law, where I teach and practice public health law. I am lucky that I get to work with the 23 health officers and the one health commissioner across the state, as well as with the Maryland Department of Health, and often with you all, as we provide technical legal assistance to state and local public health officials, legislators, advocacy organizations, researchers, and community groups who are working in the public health space and need to better understand source and scope of public health power, who has the power, how it can be used, and what ways the law might prevent public health achievements and what opportunities the law gives for public health achievements. So in addition to Me Too, on the entire panel that you've heard from here today, emphasizing in particular the consumer representation as well as the expanded representation of health officers, whether it's rural, suburban, or urban, or medium, small, large. I do think we need to have a more diverse representation from health officers. I want to add, and obviously I'm biased, that there be assured legal guidance available either through membership on the commission or in a guidance role to the commission, because as Dr. Polsky indicated, not having the finance people there can make you come up with policies that are great ideas, that might have a strong evidence base and real support in the community. But if the funds aren't there, you can't accomplish your goal. The same thing is true with legal hurdles, right? If you're developing your policies without understanding the who, what, where, why, whens, and hows of the law, you might end up with policies that just aren't realistic. So for that reason, I encourage you to embed either directly or indirectly throughout this legislation that there is a role for lawyers here, much as I know you benefit from Ms. Hopwood being your lawyer. Thank you.
Thank you. Thank you. Yeah. Next, please.
All right. Good afternoon, Chair Pina, Vice Chair Kelly, and members of the Health and Governmental Operations Committee. My name is Dr. Oluwatosin Olateju. I'm a doctor of public health and an assistant professor of nursing. I'm here on behalf of the Maryland Public Health Association, where I currently serve as the co-chair for the Advocacy Committee. We are a state affiliate of the Maryland Public Health Association and are the only public health-focused organization in our state, driven by members from all areas of public health, including practitioners, researchers, public health officers, clinicians, and students, among others. Vice Chair Kelly, we're thrilled to see the proposal of HB 214 to create a commission on public health. In the 20th century, 25 of the 30 years of lifespan gained were due to public health efforts and interventions such as vaccines, family planning, fluoride in water, motor vehicle safety regulations. Recognizing public health impact and important role in efficiently and effectively improving the overall health and well-being of population and ensuring appropriate funding and support must continue to be the priorities in our state. We appreciate that the foundational areas and capabilities that the Commission will cover fall in line with the CDC's description of health systems and 10 essential public health services. Furthermore, this bill is in congruence with one of the Healthy People 2030's goal to engage leadership, key constituents, and public health across multiple sectors to take action and design policies that would improve the health and well-being of all. Additionally, members that make up the Commission cover for a wide breadth of expertise in the health and public health, from all health systems to community partnerships to behavioral health. We would like to ask if the Maryland Public Health Association could be considered as an additional member of this commission. While we have members that could easily fill many positions that have been defined, we function as an umbrella organization that holds expertise in all fields and have many relationships, from organizations from across the state, many who are not represented in the defined positions, but can speak, as one voice. Today we urge that, the Commission, supports this bill. We are in favor. Thank you.
Thank you for your
so much.
testimony. We appreciate it. Are there any questions for all these, for any of these panelists? Seeing none, you did an excellent job. There are no questions. Thank you so much for being with us. Next, we have Mr. John Quinn. Are you here? Welcome to the committee. Go ahead, sir.
Thank you. Good afternoon.
Good
Thank
afternoon.
you, Chair Pena-Melnick, Vice Chair Kelly, and all committee members for the opportunity to testify today on this important legislation. I come to you as a proud resident of Maryland in District 47, and my testimony today is submitted on behalf of the DFLA Education Fund, a registered 501c3 nonprofit dedicated to advancing the consistent life ethic. Among other policy areas, we advocate for accessible health care and just solutions to racial inequalities. I want to use this brief time to expand upon my written testimony, which I would also encourage you to read. And I especially want to draw your attention to a proposal included in that written testimony that Maryland aim as an explicit policy goal for public health to achieve zero infant and maternal mortality. We find the benefits of this commission fairly straightforward, and we welcome the openness we've heard today to amending the legislation. In fact, one of the amendments we proposed on the second page of our written testimony speaks to the very first change that was discussed here today about narrowing the factors. Our position is basically that we welcome the three factors that are currently named, and any factors that are assigned to this commission we'd like to see explicitly spelled out for the sake of transparency. I also wanted to briefly address Delegate Shalali's question. I have not read the testimony that was mentioned. I cannot speak on their behalf. But I did find it crossed my mind that the reference to family health on page 2 could potentially authorize this committee to research and think about abortion. So just want to throw that out there as an interpretation that I think would be consistent with current Maryland law. So thank you for your time, and we look forward to working with you on this legislation, and I welcome any questions you might have.
Are there any questions for this witness? Seeing none, thank you so much for being here today. We really appreciate your testimony, and the bill will go to subcommittee, so they'll take everything into consideration. Thank you. Next, we have for the committee, we have two virtual witnesses. The first one is Ms. Stephanie Clapper, and if you will be so kind and just give her a second to come on. And the testimony is favorable. Good afternoon. You may get started.
Thank you. Thank you, Chair Peña-Melnick and Vice Chair Kelly and members of the committee for this opportunity. I'm Stephanie Clapper from Maryland Citizens Health Initiative. We're a consumer advocacy group, and our mission is quality, affordable health care for all Marylanders. We are a Me Too on House Bill 214. We encourage you to do a favor report, and we also believe in the importance of elevating consumer voices on commissions such as this, and would love to get involved in any way that we can to be helpful. Thank you to the committee for your leadership and all of your past healthcare initiatives like the Health Equity Resource Act, and we believe that this bill will help Maryland continue to lead.
Thank you very much, and your time was excellent. Are there any questions for this witness? Seeing none, you have a wonderful afternoon. Next we have, it's an unfavorable, and it's actually Ms. Laura Bugley. Good afternoon. Let's give her a second to come on. We have to do one at a time, so thank you for your patience. Good afternoon. You may get started.
Good afternoon, Madam Chair, members of the committee, for the opportunity to speak with you today. I'm Laura Bogley, Executive Director for Maryland Right to Life. On behalf of our members across the state, I oppose House Bill 214 to the extent that it will further entangle Maryland as the state sponsor of the abortion industry. The bill uses the term maternal health without revealing that in Maryland, that includes the full spectrum of reproductive services, including abortion. We do not agree that abortion is a foundational public health service and that local health departments should be forced to participate in. And we ask the committee to specifically exclude abortion from this definition. Just as a reminder, the state has considered abortion clinic providers as essential providers of essential services and excluded them from COVID closures. Nevertheless, they did receive COVID relief grants through the Department of Health. So abortion is legal in Maryland and will remain legal unless or until the Assembly decides to repeal it. But the people of Maryland do not support abortion extremism. Even when Roe decriminalized abortion, nothing in law required this state to aid abortionists in committing abortions. The state has no affirmative duty to establish access to abortion nor to subsidize corporate abortion. Abortion is not healthcare and is never medically necessary. Sadly, for nearly 50 years, this assembly has allowed the loudest voices to drown out the voice of reason. Because of this abortion extremism, the state of Maryland and Department of Health have failed to adequately meet the legitimate needs of women and families. In fact, 3 in 4 women say they had abortions because they felt they had no other choice. 50 years of legal abortion has failed to cure the underlying socioeconomic ills that women face in raising our families. And we know that abortion actually increases the risk of maternal health, including infertility, future miscarriage and preterm births, and even maternal deaths. And to address health disparities, abortion is the leading killer of Black lives in America. Rather than adapt to advances in science that better meet the needs of women, the Assembly has taken a regressive approach. But today is a new day, and you have new leadership. So as you establish this new Commission on Health in a post-war America, we ask that you not be led, but to lead with the radical belief that all lives matter and that this state can advance the health of mothers without sacrificing children. The public supports public policy and programs that support the lives of both mothers and children. Finally, we ask that you restore the integrity of medical science in our state so that Maryland may once again be known for our medical excellence rather than substandard care. For these reasons, I urge your amendment or your unfavorable report. Thank you.
Our pleasure. Are there any questions for this witness? Seeing none, thank you so much for coming to HGO. We really appreciate your testimony, and you have a blessed evening. Next, we have, and please give it a second or two, we do have another virtual witness, and it's actually our last one for the evening, and that is Dana Schulze. She's not? She's not here? Okay. So she's not here, I've been told. So this actually concludes the testimony on House Bill 214. And for the committee, I hope you get some rest, and thank you for your attention. For those of you that were here today, we value your input, and you have a great day. And for the staff, thank you so much for, you encounter a lot of technical difficulties. Thank you for your patience, okay?
I know it's pretty seamless, Jocelyn. I think it went well, the technical and all.
We try.
It's hard to put all the panels of people together like that.
Yeah, we're trying to figure it out. Great job.
Yeah, good. It's gonna be a headache to figure out all these amendments.
Did the Department of Health give you their amendment?
Yeah, and we have them, and Sharpsky is speaking.